Okay, most people who think about WIC don't even know that there is a food package 3. So I would say this is sort of our orphan of the whole program. But I do think it's very important, maybe underutilized, and probably the one we know the least about. But with the recommendations of the last review, all of the special dietary needs were put into food package 3 because it used to be administratively dealt with a little bit differently. And in general, what you think about is this is special formulas, and then the reciprocal is that the only thing that's restricted should be those items that should not be in the package because of the participant's health. So these really are not things that are that hard to administer in the sense of you don't have to be taking away a lot of things, mostly because most of the WIC food package is very healthy and very generalizable. Again, the most utilization and the time we think of it the most, I think, is for infants. The most classic example would be children who are born, babies who are born with inborn errors of metabolism. So you might think of maple syrup urine disease or PKU or something like that. But the other thing that seems like we need to take a better look at is the follow-up of infants who are born at low birth weight. So the premature infants, small for gestational age, and then, quote, other medical problems or dietary issues. So I tried to get, and Jay could help with this, but there's very specific federal language, but I found it still quite broadly based in the sense of how might we serve these very at-risk infants better. So I don't see the package as being very restrictive. Generally, what you would be looking at in an implementation is thickened formula, special formulas. Again, I think about the post-preemie being discharged. Maybe some consideration of using the powdered formulas because that gives you the ability to concentrate calories, that sort of thing. And again, no call for restricting anything else. So this isn't, if you will, a cost neutral. If you're on that really expensive MSUD product, it doesn't mean you can't have anything else. When you look at it for the older children and women, again, it's very vague, at least to my eye. I think the most use would be for the younger children who, for health reasons, are being kept on infant formulas. And again, we see that, but right now we're thinking of as you go from being 12 months old into the 1 to 2 age category, shifting food packages in that way. It gives you the opportunity to use all those other, what we would think of in pediatrics or pediatric dietetics as the special infant formulas. So if there is a medical indication, then this is where you can get some of those things that really can be very hard to find or very expensive. And again, no other food restrictions are required to participate. As far as women who would be in the 3 typical women's packages, I could find almost nothing about how this is used. I don't know what the diagnoses would be. But again, it's something, as I think about future research and looking at doing the best we can with the program, is, and maybe some of you can add comments to how are we using this in women. So the overview is this is a full package. It would have its unique pieces that you could keep carrying on infant formula, and I would assume, again, with medical indications, some of the other kind of commercially prepared clinical nutrition kinds of things. The fruits and vegetables, the milk and milk alternatives, we've had a good bit of discussion about that, and I'll just pause here and talk about thinking of the children, the young children and infants. Again, I think we're hearing the theme that the jarred foods for in late infancy and toddlers, we don't have the uptake that we want. I don't think that means they're not needed. I think that's an opportunity for us to do better. In part, there are a couple things. One, these foods are really almost only going to be eaten by the infants and children for which they are intended. These are not foods that the older brother and sister are going to be interested in, except for jarred fruits, which are very tasty. And I could tell you stories of pediatric residents raiding the cupboard in the hospital, when you're starving, and a lot of fruit went that way. But I really do think there's something fundamental here that we've got to keep in the story, is actually these don't taste very good to adults and older children. I think that's part of why sometimes the parents, the moms, don't want them and don't like them, because we've done a very good job of getting out the added sugar and salt. If you taste these as an adult, or even as somebody less than 2 years old, they're not going to taste very good. And I think we have an identity issue here, or a consumer issue, that I'd like to see us consider in the WIC education process. Because I do think they, as you heard earlier, I think they have a potential real role to play in this. And educating the parents that it's important for the children. And by the way, these taste good to children. And again, there's really fundamental, very good research that shows some of the bitter taste and all those things that we might, and our lack of happiness with the low salt, isn't going to be translated into the acceptance of the high nutritional value food for the infants. Again, we've heard some interesting things. I think we've made a huge effort over the last few years to, when we were thinking of our cultural competency, to say, well, what, as was just talked about, do we need soy in the product? Do we need more tofu? Do we need more this, that, and the other? And I think we're still in the observational phase. But my thought would be, if those haven't really been very popular and haven't made nutritional contributions, some of the work to keep those on our food list may be more work than they're contributing to either the happiness of our clients, our participants, or to the public health benefit. So I know one of the things the committee has to keep thinking about over and over again is, how long is the list? How much does the list cost? How are we going to make trade-offs? So I think beginning to look at some of the utilization data and some of the consumer feedback, and I don't think it may be in this first 5-year review, but I think those things should certainly be kept on the table to save money and administrative costs for some other things that are going to take real efforts. Food package 3 is everything you would get for your age and condition. So again, looking at the redemption pattern, again, because we know so little of this, and again, this comes from the electronic benefit report, 1.5% of the families received a prescription for medical foods in those 3 states surveyed. You see the range there, 1.3 to 2.4. The redemption pattern is a little bit different, which I interpret as this is actually very important to the families who are getting it. That you have a 54% with a range of all redemption. We don't see that in any other group. So if this family's been identified, if we've delivered the program effectively, it means a lot to the family. 32% some redemption and only 14% not redeeming. And again, some of that may be because indications changed, and as we say, if there's a hassle factor in the general program, the hassle factor for this is probably higher. But one of my questions after I finished thinking about this is 1.5% the right number? Is that we're doing a great job and that's the only people who need it? Or is that number low because our outreach around this program is not as effective as it might be? And then looking at the other factors influencing. So as we've heard repeatedly, the Asian families are the most organized, the most bought into the program, and their redemption rates are higher. The Black families are already on the lower end of that scale. In this program, urban is doing much better than non-urban as far as redemption. Here it was interesting, the household membership, the size of the household, not the number of people from the household on the WIC program, actually had an influence. So again, to me, that felt like goodness of fit. If you're low income, big family, and you need this, then it's something you will make a real effort to get. So we clearly have, though, the non-urban Black participants as a very predictable high-risk group for not redeeming and maybe not even for getting on the program at all. So then the points to consider, and just like I said, I'm sorry I couldn't bring you more real information, but I think it is a time to think about, and it may be a time outside of this committee's purview to work with the USDA to spend a little bit of extra time thinking about this program. So in 5 years, we'll have more data for you and that sort of thing. One of the issues that I think is worth considering, and as I thought through this, I'm trying to remember, in 1996 to 2000, we did the report about having to have nutritional risk to get on WIC. Remember those old days that you actually had to be certified to get on WIC? And we went through that and showed if you met all the income criteria and all these other things, that you were very, very highly likely to have nutritional risk because of the poor food intake, poor diet quality of low-income people. But back when we had that, pediatricians and primary care physicians often had to sign the WIC authorization note. Often it was around iron deficiency anemia or at risk for it or something like that. But I feel like one of the things that's probably happened is, as we have done that, the primary care people don't know as much about WIC as they used to. And they don't know then about the special needs category. Fortunately, most of the regular healthy babies are still very much part of the program. But there may be something to the fact that this important connection between the physicians are getting out of the NICU for a preemie or having a new diagnosis may be falling through the cracks because we may not have the relationship we did. Now, all that being said, there's also a call for that can the WIC nutritionist or somebody else who's part of the WIC group and very well informed and a very good administrator, what's the balance of the burden between getting somebody signed up and continuing to keep them certified? Is that something that you need to be doing with the doctor? Again, I would say if it's a child that's got a lifetime diagnosis, hopefully the doctor and the dietitian and the social worker and everybody is very clear that using the WIC system would be a good thing for those as long as it can support the family. But I think there are a lot of other short-term diagnoses that the committee may want to think about and certainly get advice from people on the ground about how that plays out. We do talk about the ability to individually tailor some of the WIC packages, and we talk about cultural issues, but this again is a particular point that I think if you build a relationship with the family, with the affected child or adult, again, that's a chance probably to really build on this, because these are among our highest risk participants, it seems. And then one of the things that came up when we were brainstorming, I think, and even planning for this, which I had never thought of, is how does the WIC team start to help the family understand when this is not a full life benefit? How do you anticipate when you're going to be well enough to come off of this package 3? And then what do you go back to? And so just the anticipatory guidance about that. Given that I don't have a list of diagnoses or what are the prevalent issues, I don't have much more insight into that. But those were some of the things that came up with that. So I didn't even get to the yellow light. There's not enough information on package 3, although again, I believe it's really important to keep in something that we can consider doing better with in the future. Thank you.
I'd like to invite the other speakers up now for a panel discussion. In the meantime, does anyone have any clarifying questions